Hi everyone, and very good evening and welcome to the live test discussion, the quiz that we just conducted an hour ago on the Unacademy on the Telegram group. So I hope all of you have attempted the quiz. So let us start without any further delay. Before I begin, can I get a quick thumbs up in the live chat box whether the audio video is clear? If all is well, then we can start right away. And meanwhile, till the time everyone joins us, let me just brief you about the free classes that are going on currently on the Unacademy platform. So most of you have been with me over these classes and they have gone on for all these days. So today was our 4th session that we conducted, and following that we had a 15-question quiz, and now we are here for the quiz discussion. A similar session also awaits us on 2nd of December, that's day after tomorrow, and that is also going to be a crash course which will have very important questions of liver, lung, hematology, followed by a 15-question quiz on Telegram. So I always say that there are 2 very important test series that are going on Unacademy. One of them is at 8 o'clock, one is at 9 o'clock. So these are the T20 series which are going on. They are free for everyone. So I would recommend all of you to go through these and attempt them on a daily basis at 8 o'clock and 9 o'clock. This is about the Plus subscription that is available for anyone who wishes to take up the Plus subscription on Unacademy, and you have 2 options. One is of the Plus and one is of the Iconic. So as per your suitability. Also, this provides you daily live classes, structured courses, live tests, and all of those asking me for a PDF of the PDF files of the classes. All those are available after the class is over, so you can download the same. So let's begin with today's session. Yes, everyone ready? So I hope everyone's gone through the quiz, and now let's discuss it. Okay, so number 1 question was this. So here we had a factory worker, so we'll keep highlighting the important points. We had a factory worker who is working in a factory for the past 20 years and is now presenting with pleural thickening. That is a very important hint given out here, presenting with pleural thickening and fibrosis. So some histopathology image, as they've said, is given in front of you and you have to give the diagnosis. So I'll just zoom into this. So first and foremost, pleural thickening was hint number 1 because it's some occupational disease. Yes, very well, as I can see many of you calling them dumbbell shaped bodies. So some occupational disease. Secondly, pleural thickening. If I zoom into that image, this is how it looks like. So can you all appreciate these dumbbell shaped brownish bodies that are there? Yes, these are all the asbestos bodies. These are the asbestos bodies, right? So the very characteristic part of it is asbestos fiber causes pleural thickening. So pleural involvement is something which is very characteristic of asbestos, number 1. Number 2, you are seeing the presence of these dumbbell shaped bodies, which again gives you another hint towards asbestos. So clearly the answer over here was asbestosis. And if I would have asked you that what is the, yes, as I see many of you answering, what is the lobe predilection, which lobe of the lung is it going to involve, the upper lobe or the lower lobe? So remember, usually asbestos tends to affect the lower lobe, the base of the lung. That is the reason many of us also call it as asbestosis, because this tells you that the base involvement is going to be noted, right? Is this okay with everyone? Now tell me, so this is how a proper asbestos body looks like. It is actually a dumbbell shaped body, something that your body, human body, covers it with. So do you all remember that these asbestos bodies are going to have a covering of iron? Do you all remember this? There's going to be a covering of iron that is present, and that is the reason that they will stain positive for Prussian blue. Do you all remember this point that we have already discussed in our classes? So remember, what is the special stain for an asbestos body? Because it is covered with iron, you are going to call it you are going to stain it with a Prussian blue or a Pearl's stain. So will it be right that if I say that an asbestos body is the same as a ferruginous body? Can we say that, everyone? Yes or no? Can I say asbestos body can be given another name, that is ferruginous bodies? So is this exactly the same or is there any difference? So you will say that, ma'am, okay, asbestos tells me about asbestos fibers, ferru tells me about iron, correct? So can I say all asbestos bodies will be covered with iron? So I can call them ferruginous bodies. But will all ferruginous bodies have asbestos in it? Is the other way around true? No. So remember, if you've got this as a dumbbell shaped asbestos body, this is correct that you will have it covered with iron. So you will say asbestos body is ferruginous body. But will a ferruginous body always have asbestos in the center? Not necessarily. It is something that you can also see with silicosis. It is something you can also see with coal workers pneumoconiosis. It is something you can also see with asbestos fiber. So basically depends what is the fiber in the center, right? So fiber could be silica, it could be asbestos, it could be coal, and you've just covered it with iron. That is a ferruginous body. You don't know what is in the center. And when you definitely know that, okay, asbestos is in the center, you call it an asbestos body. So that's a very frequently put up doubt or by many students, that is asbestos and ferruginous body is the same. So now you know asbestos body is definitely a ferruginous body, but if I say ferruginous, I'm just sure of iron. I don't know what is sitting inside. That could be anything. I hope question number 1 was clear to everyone. So we move on to question number 2, which I've just put up because I discussed it an hour ago on the Unacademy platform. So I just wanted all of you to attempt this question. It was, heart failure cells are actually what? So if you all remember, I'm not going to discuss this in detail because we just studied it. Heart failure cells were the, yes, many of you are right. They are seen in which heart failure? I just told you, you see them in the lungs and they are seen in left-sided heart failure. They are seen in left-sided heart failure, and what are they? So what are they in the lungs? They are alveolar macrophages. Who will tell me what do these macrophages contain? Just now we studied it. They are alveolar macrophages which contain what? So they contain, perfect, they contain hemosiderin. Correct guys, they contain hemosiderin. Amazing. So all of you got that right. You see it in the lungs. They are macrophages with hemosiderin and they are going to be seen in left-sided heart failure. So again the same thing. If they contain hemosiderin, what is the special stain that I'm going to use for them? Again the same stain, iron stain. So I'm going to use the pearl stain or the Prussian blue. Same answer for this. So not too much of detail on this because all of you already know about it. Let's move on to the next question. Okay, this is a question where all of you have to answer because it's a factual question. Infraclavicular lesion of tuberculosis is known as, options were Simon's, Assman's focus, Pearl's focus and Gone focus. And the answer was Assman focus. So can we do something? Can I give you a list and can you fill in the blanks of all those foci of TB? I think that will be a very good exercise to carry out. So let me ask you, number 1, can you tell me where is a Gone focus present? In TB, when we say Gone focus, so everyone start typing faster. When I say Gone focus is TB that is present in the lungs. Okay. Next, if I make this focus into a complex, then what is it? Okay, you'll say, ma'am, Gone will always refer to the lungs. So TB is there in the lungs. But other than that, it's also in the lymph nodes. So it's in the hilar lymph nodes. Perfect. Many of you are right. Great, guys. So remember, Gone focus is in the lungs and complex is lungs plus lymph node. Who will tell me Ranke is complex? Who will tell me Ranke is complex? So Ranke is complex. See, Ranke has the word or the pronunciation of calcium, Ranke. So Ranke is going to show you calcification. I hope this is clear to everyone. Ranke is going to show you calcification. Great. Next one, that is the question they put up to you. See, I'm going to draw a lung over here. And all of you know what goes very close to the apex of the lung is the clavicle bone. You know this. You know that there is a clavicle which passes and a little bit of the lung projects above it. So can I draw 3 parts? 1, next is 2 and next is 3. I've drawn 3 dots. Listen to this very carefully. Number 1, I've drawn apex of the lung. See over here, this is, I'm writing it with A, apex of the lung. Okay. Can I say there's a very tiny portion supraclavicular? Can we put it up like this? Supraclavicular. Agreed, guys? So can I label this as S, supraclavicular? And then we've got a major portion which is infraclavicular. Do you agree with these three parts of foci or regions of the lung? So remember, we have a apex, a supraclavicular, infraclavicular region. When I say apex, supraclavicular, infraclavicular, your mnemonic is SPA. So apex, then supraclavicular, then infraclavicular is labeled as Simon focus, Pearl's focus, and Assman focus. What was the question given to you? What was the question given to you? What is infraclavicular focus? So now you know infraclavicular focus is the Assman focus. So whenever you get confused in the lung, remember SPA. It is Simon, Pearl's, Assman. Very simple. Are we clear on this? But there's a twist in the story. Instead of Simon, if I end up writing Simon's, if I end up writing Simon's focus, then what are we going to talk about? Simon's focus. Then this is TB occurring in the liver. Perfect. TB in the liver is Simon. And lastly, if I say Wiegert, last two, Wiegert's focus, who answers that for me? Wiegert's focus of TB, where is it? Perfect. It's in the blood vessels. Wiegert is in the blood vessels. Easiest I've kept for the end. Rick's focus. So brainy people are always rich. Brainy people are always rich. Remember, Rich's focus is going to occur in the brain. Are we clear with the foci? Should we do a quick recap? Ghorn focus is in the lungs. Ghorn complex is in the lung and lymph node. Ranke's complex is calcification. For the lung, if you take apex, supra, infra, you have SPA, SPA, Simon, Pearl, Assman. On the other hand, Simon is referred to as the liver, Wiegert is referred to as blood vessel, and Rick's focus as the brain. So the question that I clearly gave you was infraclavicular lesion of TB is known as Assman focus. Quick recap, tell me, Simon would have been the answer of? Everyone, Simon would have been the answer of? Simon, so that would have been the apex. Pearls would have been the answer of? Supraclavicular. And Ghorn focus would have been the focus in the lungs as a whole. Many of you said liver. Guys, why liver? Liver is Simoned. Liver was Simoned, not Simon's. Simoned. Okay, that is the difference. So remember, Simon is apex. Okay, no confusion on that. Let's go to the next question. All are true about silicosis except most common pneumoconiosis, lower lobe is usually involved, pleural plaque is seen, birefringent crystals are seen. So I'll tell you one rule and you'll never get this wrong. See, all are true except, let's read one by one. Most common pneumoconiosis, this is true. Silicosis is the most common pneumoconiosis. Pleural plaques are seen, definitely. You can see pleura involvement, you can see nodular fibrosis. These are the 2 points that you can see in the lungs with silicosis. Pleural plaques and nodular fibrosis can be seen. Birefringent crystals are seen. Yes, that is how you do the identification. Birefringent crystals are seen. So what was the false statement? What was the answer? Lower lobe is usually involved. Guys, I'll tell you one basic rule today, which will always help you crack the questions. Remember, all pneumoconiosis, please write this with me, it's important. All pneumoconiosis are going to involve the upper lobe except, I think we got this right in the beginning, except asbestosis, because asbestosis will be base. Asbestosis will involve the lower lobe. Asbestosis will involve the base of the lungs. Asbestosis, that is how we called it. Remember, instead of calling it asbestosis, now we'll call it bastosis, because this involves the base, lower lobe. All other pneumoconiosis involve the upper lobe. So someone's asked me, ma'am, pleural plaque ho sakta hai? Definitely. See, silica can cause 3 things. Learn the 3 things with me, guys. First, it can cause nodular fibrosis in the lungs, number 1. Number 2, it can cause pleural plaque. And number 3, can you tell me any radiological finding of the lymph nodes? Can you tell me any radiological finding of the lymph nodes? Have you heard of eggshell calcification? Have we heard of eggshell calcification, guys? Yes. So that is another thing that it can cause. So remember, nodular fibrosis, pleural plaque and eggshell calcification. These are the things which silica can cause. It is the most common pneumoconiosis. It usually involves upper lobe and you have to see it with the help of birefringent crystals. So what was the answer over here? False statement. It is lower lobe involvement. That's false. Okay, I hope everyone's clear up till now. Moving on to the next one. Okay, so this is a question we did yesterday also, and I framed it in another manner to see if you can catch it. There's a 35-year-old male patient who presents for the evaluation of hemoptysis. A chest X-ray reveals bilateral pulmonary consolidation. On further questioning, he admits of having hematuria. So 2-organ involvement, lung, kidney. Hematuria hai, so RBC casts are seen. 400 ml of urine is voided in 24 hours. What is the most likely cause of hematuria and hemoptysis? Very good. Everyone saying that, ma'am, we are thinking of good pasture syndrome. You are on track, guys. So this is just to revise what we did yesterday, just to know if you were you were good with what we studied yesterday. Perfect. Good pasture syndrome is something that you see showing basement membrane antibodies. Can you quickly revise with me the 1, 2, 3, 4 of good pasture syndrome? Everyone from today's class, from today's Unacademy class, tell me what was 1. Remember, 1 stands for type 1 RPGN. Remember this? What was with 2? Remember, it is a type 2 hypersensitivity reaction. Yes. There are antibodies against the alpha 3 chain, that's the 3, alpha 3 chain of which collagen? Everyone remembers this, type 4 collagen. Amazing, guys. So remember 1, 2, 3, 4 of good pasture. It's type 1 RPGN, type 2 hypersensitivity, antibodies against alpha 3 chain of type 4 collagen. So we've got that right. I hope it's okay with everyone. So clearly the 2 organs that are affected in good pasture are going to be the lungs and the kidney. But tell me, how is the patient going to present? So you'll say, ma'am, it's given in the question. When lung involvement is there, patient will show me hemoptysis. When kidney involvement is there, patient will show me hematuria. But what is the most common cause of death? Can you tell me this? Can you tell me the most common cause of death in a patient with good pasture syndrome? Remember, kidney failure. The most common cause of death is uremia. The most common cause of death is uremia. Are we okay with this, everyone? Good. Renal cause, everyone said. Great, you know this. Most common cause of death, uremia. So we got this question right. We had a clear-cut case of two organs, hematuria, hemoptysis. Antiglomerular basement membrane antibodies was the answer. Perfect. Okay, moving on, coming to the next one. Very interesting question. There's a 60-year-old woman who has been a cigarette smoker since the age of 18. Okay, moving on, she works as a dispatcher for a trucking company. She has had several episodes of hemoptysis. Okay, lung involvement we are talking about in the past 2 weeks with fever, fatigue, headache, nausea, anorexia. On physical examination, her sensorium is clouded. A chest radiograph shows an ill-defined hilar mass. A transbronchial lung biopsy is performed. Okay, lung biopsy shows me something which is shown over here. Which of the following lab tests is most likely to be present in this patient? What is your answer? Let me first ask you guys your answer, guys. What is it? Lymphopenia, hypercalcemia, hypergamma-globulinemia or hyponatremia? Tell me the tumor and tell me the answer together. Yes. So if you are confused with the tumor, I can zoom into it and I can show you the tumor. So this is the tumor that you have. You will say, ma'am, I'm seeing some blue color cells. Okay, I'm seeing some blue color cells. But then in this part of the slide, I'm seeing all those cells are kind of smudging. They are kind of, streaks are forming. They are smudging. Yes. So we've got a couple of hints out here. See, number one, you've got small cells. Number two, those cells are very fragile. Why am I saying they're very weak? They're very fragile because they are smudging. Because they are smudging. That is a very, very characteristic feature of small cell lung cancer, guys. Small cell lung cancer, and that is why smoking was given as a very characteristic point. It is associated with smoking. Small cell lung cancer is associated with smoking. It shows you this smudging, small cells which kind of break apart, smudging. So now tell me, many of you saying hypercalcemia is, ma'am, the paraneoplastic syndrome. Is hypercalcemia your paraneoplastic syndrome for small cell lung cancer? Is it? Or is hypercalcemia the paraneoplastic syndrome for squamous cell lung cancer? I think that is where the confusion is happening. Yes, correct, Dr. Usha. Hypercalcemia. So let me just give you a quick recap. What are the tumors you know of? You know of squamous cell carcinoma. Okay, you know of adenocarcinoma, you know of small cell cancer, and you know of large cell cancer. Okay, so let me ask you, what is the paraneoplastic syndrome with squamous cell carcinoma? You will say, ma'am, increase in calcium. Hypercalcemia. Agreed. Okay. Who will tell me the paraneoplastic syndrome for adenocarcinoma? Yes, guys, adenocarcinoma of the lung. Paraneoplastic syndromes are always important. Since neoplasia chapter I've been telling you, you have to study it. This adenocarcinoma lung shows you the same paraneoplastic syndrome as the pancreas. Perfect, excellent. We have the Trozeu's phenomena or perfect. Migratory, I'll write it down. Migratory, great guys. Thrombophlebitis, not SIADH over here. Not SIADH over here. So remember, migratory thrombophlebitis, Trozeu's phenomena. Pancreatic cancer also shows you this, na? Surgery question. Pancreatic cancer, lung adenocarcinoma, they show you Trozeu's phenomena. So what is it? Migratory, migrating. Thrombo means thrombus. Phlebitis means inflammation of the veins. So remember, inflammation of the veins and the thrombus, which is migrating from one vein to another, So thrombus and inflammation, migratory concept. That is something you see with adeno. So what is, I'm still not coming to the point, what is the paraneoplastic syndrome with large cell lung cancer? With large cell lung cancer, it is gynecomastia. With large cell lung cancer, it is large cell shows you enlargement of breast. Remember like this, large cell will show you enlargement of breast. So finally, what are we left with? Small cell, your topic today of the question. You know, maximum long list comes here. So can I say most commonly associated with paraneoplastic syndromes is small cell? And the most common is SIADH. Very good. Many of you got it right. SIADH, Cushing syndrome, and Lambert-Eaton syndrome. So longest list I have written over here. What are the paraneoplastic syndromes with small cell? SIADH, Cushing syndrome, and Lambert-Eaton syndrome. Yes. Now, let's get back. So now you'll say, ma'am, answer should have been one of these. Let us get back to our question. Question was, do we have lymphopenia? No, I've not read that. Hypercalcemia? No, because hypercalcemia should have been with squamous cell cancer. Okay. Hypergammaglobulinemia? I've not read that. Hyponatremia, guys. Hyponatremia is something you see with SIADH. Hyponatremia is something that you see with syndrome of inappropriate ADH secretion. Yes, everyone got that? So this is SIADH causing hyponatremia. That is how you had to correlate. This is small cell lung cancer showing you hyponatremia because of SIADH. So definitely the tumors are very, very important of the lung. Now all the more important because now you know this is a recent favorite that the examiners are discussing more, and paraneoplastic syndromes are an all-time favorite. So please learn this properly. Another question of lung and micro coming mixed for you. Okay, next question. Another question of lung and micro mixed for you. So the image might be getting obscured a little. I'll try to shift it this side. Perfect, let me know. So a 50-year-old resident of Arizona has a cough which has persisted for 1 month. Okay, 50-year-old, 1 month cough. Physical examination, temperature is 38.1 degrees. On a chest radiograph, there is a 3.5 centimeter opacity with a central cavitation in the right apical region. An open lung biopsy is performed. Open lung biopsy is performed to exclude cancer, because see, there's a mass, there's a cavity, age is 50 years, cough is there, so we have to rule out cancer. Biopsy is done, and microscopy shows you something that is seen over here, which also shows you specimen having granulomas. See, they've given the description. Granulomas are there, containing 60 micrometer spherules filled with small round structures. So even if you don't know the photo they've given you, there are some 60 micrometer round structures. Inside them there are further round structures. Which of these is most likely? Do you remember seeing this picture anywhere with me under the microbiology part? We've discussed it in the plus courses in microbiology. So the answer to this is coccidioidomycosis. Let me show you this photo first. Have a look at it. Look at this. Exactly what was given. They said that you have some large 60 micrometer spherules. Can everyone appreciate these? These are 60 micrometer spherules, and these are going to be filled with further small spores. So remember, this is the classical description of coccidioidomycosis. Coccidioidomycosis. So here guys, the photo was your giveaway. Now let me get back. There are some layers in that question that I want to highlight. Do you know why was Mycobacterium, Histoplasma, Aspergillus given over here? Because many students were marking this. I was seeing on the Telegram quiz today. Why? Because यहाँ पर लिखा था there is a central cavitation that is seen. Whenever a radiologist tells you about a cavity, there's a cavity present, there are some 1, 2, 3, 4 points that come to everyone's mind. Can you help me enumerate a few? When they say cavity, so let's start from there. When they say cavity, what should come to your mind? Histoplasma can cause cavity. Next. Do you remember which type of TB causes cavity? Primary TB or secondary TB? In the lung, which TB causes cavity? Cavitation is a feature with reactivated or secondary TB. Okay. Do you know that within a cavity, an aspergillus tends to grow? We call it aspergilloma. We can have aspergilloma. That is, within some cavity, aspergillus ball is growing. Yes, everyone's written that. Weren't these your 3 options? Weren't your options Histoplasma, Mycobacterium, Aspergillus fumigatus? First 3 options to confuse you. That is what I wrote. Also, does Mycobacterium show you? Look at the next hint. They said caseating granulomas. Does MTB show you caseating granulomas? Yes. Does Histoplasma show you? Yes. Can Aspergillus show you? Yes. Coccidioidomycosis, we made a diagnosis primarily on the basis of this photo. That is why this photo from this microbio photo was utmost important. Also, the patient being from Arizona was a very big hint, because coccidioidomycosis, that is where it is predominant. Are we clear guys? A little insight into micropath medicine mixture, good correlation. I hope it's something you've learned. Also, to complete my list of cavities, can you tell me which cancer very commonly presents with cavitation? So remember, squamous cell carcinoma also tends to present with cavitation. That is the cancer which can cause cavitation. So done with that as well. Should we go on to the next one? Yes, everyone. So this is another one. So just now discussing couple of lung questions. So maybe another one here. PTH-like substances is produced by which of the following lung malignancy? I expect everyone to answer this now, because I've taught you everything about it. PTH-like substance. So what will a PTH-like substance do? Think that ways. What will a PTH-like substance do? Yes. Think what can it elevate? What can it elevate? Everyone saying, line say everyone is saying squamous cell carcinoma. Why? PTH-like substance, parathyroid hormone-like substance will increase the calcium levels, hypercalcemia, and you know hypercalcemia is a paraneoplastic syndrome with squamous cell carcinoma of the lung. Perfect, simple one. Coming to the next question. I hope everyone gets this right. So there you have a question from jumping a little bit to liver. 54-year-old patient presented with jaundice, raised direct bilirubin, and presence of P-ANCA antibody. Liver biopsy shows something that is shown over here, which might be getting obscured a little. I'm sorry for that. So what you have to see out here, you have to tell me which of the following is true regarding the same. Associated with ulcerative colitis, on histology there is circumferential onion skin fibrosis around the duct. Seen with P-ANCA was there in the question only. All of the above. Let us study about it. What disease is it? Very good. I've got a answer from Dr. Sayathan. I hope I got your name right. Sayanthan, I'm sorry. So yes, all this is primary sclerosing cholangitis. Let us talk about it. First, let us see the picture. This was the photo, guys. This was the photo. Do you see there is a bile duct in the center? We've got a bile duct in the center. And around the bile duct you've got fibrosis. So this is a bile duct in the center, and around that you've got fibrosis, which is looking like onion skinning. So it's looking like onion skinning. That is how we always pick up primary sclerosing cholangitis. So now what are we going to do? I'm going to tell you some amazing mnemonics for primary sclerosing cholangitis. Can anyone tell me? Primary sclerosing cholangitis is confused with what? What do I have to compare it with? It's a biliary disease. So primary sclerosing cholangitis. If I teach you this, one more question you will be able to solve. Primary biliary cholangitis or cirrhosis. Yes. Primary biliary cholangitis or cirrhosis. These two you always confuse. And today I'll tell you some tricks to learn them. See, if I ask you they are biliary diseases, means they involve bile duct. Intrahepatic bile duct or extrahepatic bile duct? Very simple. See, biliary has I and I. Sclerosing has both E and I. So can I say biliary will involve intrahepatic bile duct? Because it has only I's, it will involve intrahepatic bile duct. And sclerosing has both E and I, so this will involve extra and intrahepatic bile duct. Do you all agree with me on point number 1? Point number 2. Remember, biliary cholangitis is associated with anti-mitochondrial antibody. Anti-mitochondrial antibody, that is important. And primary sclerosing cholangitis, I just told you, is associated with P-ANCA. See guys, P will remind you, PA will remind you of Papa. So this is more common in males. This is more common in males. AMA, some people like learning it as Amma, so mother, so females. This is most commonly seen in females. This is most commonly seen in females. Did we all get that right? Yes. So remember, AMA, anti-mitochondrial antibody, more commonly seen with, or primary biliary cholangitis, more commonly seen with females, and primary sclerosing cholangitis, P-ANCA, more commonly seen with males. Are we clear with this, everyone? Yes. Okay, so which out of these, if I say, which out of these is going to show me the presence of, just a second please, I think there's a problem with the, is the screen visible to all of you? Yes, I think it's back, and I hope it's visible to all of you now. Yes? Okay, great. Sorry for the small interruption. So that is what I was asking you now. Which out of these is going to show you onion skinning? I just taught you that onion skinning is something that you will see with primary sclerosing cholangitis. Onion skinning is something that you will see with primary sclerosing cholangitis. Okay with everyone? So let me get back to the question and attempt it again because there was a small interruption. So I have a patient with jaundice and I have a patient who has P-ANCA antibody. So P-ANCA should remind you of what? PBC or PSC? It is going to remind you of PSC. So number one, most common antibody, P-ANCA, because PSC, fine. I'm seeing a picture. The picture is showing me this onion skinning. Again, I'm thinking of PSC. Okay, so option number B also seems fine for me. It shows circumferential onion skin fibrosis around the duct. Is it associated with ulcerative colitis? Yes. Why? Because guys, yesterday only I was teaching you what is the antibody with ulcerative colitis. Which antibody is seen in ulcerative colitis patients? It is P-ANCA antibody. It is P-ANCA antibody. So same, all of the above are correct out here. Are we okay with this? Yes, everyone. Should we move ahead? No confusion? Okay. Coming to the next one. So I hope everyone also gets this right. It's a simple one, little lengthy but not tough. Okay, next one. Let's read it together. 47-year-old man presents to the outpatient clinic with complaints of heartburn, chest pain. Duration 6 months. His pain is retrosternal and was initially associated with intake of solid foods. After that, it has become for liquids as well. Antacids do not relieve his pain anymore. Physical examination mein everything up till now is normal. Hemoglobin is a little low, 10. White blood cells normal, 5,000. Platelet count normal, 1,68,000. Okay. The endoscopy shows an exophytic mass in the lower third of the esophagus. Exophytic mass should immediately not make you think of any ulcer or stricture. It should make you think of cancer. Exophytic mass. Now all that you had to do was an exophytic mass in the lower 1/3. So yes, very good guys. The answer is adenocarcinoma. Correct. So why did we come to this conclusion? Because first and foremost, my entire history is of reflux disease. My entire history out here is of reflux disease. So number one point, we are talking about gastroesophageal reflux disease. He's complaining of heartburn, chest pain. Antacids are also now not relieving it. Now he's got an exophytic mass in the lower 1/3. So see, in the esophagus, lower 1/3, mostly we have adenocarcinoma. And in the middle 1/3, we have squamous cell carcinoma. Why so? Why in the lower 1/3 are we talking about adenocarcinoma? Why? Because this is the area where GERD will occur. Gastroesophageal reflux disease will occur. Patient will have Barrett's esophagus, correct? And this Barrett's esophagus will then transform into adenocarcinoma. So the lower 1/3 exophytic mass will always hint you towards Barrett's esophagus leading to adenocarcinoma. Yes, metaplasia had happened because constantly acid was coming back. Acid was regurgitating, constantly coming back. So it was causing reflux, metaplasia, Barrett's esophagus, adenocarcinoma. Are we okay with this, everyone? So the history was very long, but at the end of the day, the question was very simple, and that is, I just wanted to put up this question so that that mental block that all of you have, that you know it is a question which is going to be very difficult. No. Just because you get a lengthy question, like I always say, take the retrospective approach. The last 2 lines will really help you solve the rest of the question. Here the last 2 lines said that an endoscopy is showing you an exophytic mass in the lower 1/3 of the esophagus. That pretty much gives you the answer. Rest of the history is something that you can definitely not, you can read it accordingly. Are we okay with this, everyone? Sorted? Okay, so now there was one question which I'll just ask you offhand because I could not bring it up from Telegram. It wasn't allowing me to. So next question, ma'am, why is HB reduced? See, this could be associated with this or not associated with this. Firstly, there's a mass that is present. Maybe the patient was having difficulty in eating. He was having difficulty in eating solid foods, later on difficulty in having liquids as well. So it could very well be nutritional. We do not know any history of blood loss, so maybe this could be some concomitant blood loss also. So first of all, from this history, I would say dietary intake has reduced. So maybe it could be a nutritional deficiency because of which the iron has gone down and the hemoglobin has gone down. But we don't know the exact profile of the patient, so it could be multifactorial also. Okay, one more question that was there in today's quiz, which I just put up after the class. Co-deletion 1p19q. Anyone who can tell me co-deletion 1p19q? Simple question it was. I hope everyone got it right. It was oligodendroglioma. Okay, it was oligodendroglioma. I had just put it up as a revision because all of us had, immediately discussed it in class some time back. So that is the reason that I had put it up. All of you okay with the questions? Yes. Anyone having any problem? Any confusion, guys? Any confusion? Last question on your way. Grossly pigmented liver is seen in. So the last question for the quiz. Yes. What's your answer? Rotor, Crigler-Najjar, Gilbert's or Dubin-Johnson? Grossly pigmented liver. Basically, simple way hai, dark liver. Dark liver is seen in Dubin-Johnson. Dark liver is seen in Dubin-Johnson. You'll never forget it. In one slide, I want to teach all of you these syndromes and you'll never have a problem with this. That's the last thing that we've got to discuss today. What are these syndromes? See, tell me which syndromes there's an increase in unconjugated bilirubin. Who will tell me? The syndromes in which there's an increase in unconjugated bilirubin. There are two. One is Crigler-Najjar type 1, Crigler-Najjar type 2 and Gilbert syndrome. So remember, Crigler-Najjar type 1, Crigler-Najjar type 2 and Gilbert syndrome are your increase in unconjugated bilirubin. Why is unconjugated bilirubin increasing? Anyone? What enzyme is deficient? You know all this. There's a deficiency of perfect UDP glucuronil transferase. There's a deficiency of UDP glucuronil transferase. पता है क्या करना है? 100% deficiency. In the first one, there is 100% deficiency. Zero level of UDP glucuronil transferase. This person doesn't have UDP glucuronil transferase. Will such a person survive? Will such a person survive? Not at all. Can I say 100% fatal? Can I say 100% fatal? Will not survive. Okay. In Crigler-Najjar type 2, there is a partial deficiency. Maybe 40% deficiency, 50% deficiency, partial deficiency. Will this patient survive? Yes, this patient can survive provided you give the patient treatment with a drug that is phenobarbital. Treatment with a drug that is phenobarbital. So because partial deficiency hai, phenobarbital can increase the levels of the enzyme and can make the patient fight against it. Can help. Okay. Gilbert is even lesser. Gilbert is a very, very, very mild deficiency. Maybe in day-to-day life, the patient doesn't even get to know. It's a very, very, very mild deficiency. Only in scenarios of stress will it manifest. Like if the patient has fever or if the patient is pregnant. So whenever the body is under some kind of stress, will this disease manifest. So can I say it's a decreasing order? Crigler-Najjar type 1, there's a 100% deficiency. Crigler-Najjar type 2, there's a partial deficiency. Gilbert syndrome is a very, very mild deficiency. All of these will have increase in unconjugated bilirubin. So which are the ones which have an increase in conjugated bilirubin? Last two. Which are the ones which have an increase in conjugated bilirubin? Remember conjugate. Conjugate means together. So doctors are together. Doctors are always together. So remember Dubin-Johnson, excellent. Everyone knows this. Dubin-Johnson and Rotor syndrome. So over here there is increase in conjugated bilirubin. Remember conjugated, doctor. Conjugated, doctor. Out of which of these has a pigmented liver? Dark liver, it's Dubin-Johnson. So remember, dark liver or deeply pigmented liver is Dubin-Johnson. Last question for the day. Who will tell me what is the name of this pigment? What is the name of this pigment which makes it a dark color, which gives it a dark color? Last question for the day. Let's see who answers that. Perfect. It is epinephrine. It is epinephrine. Great. Yes. So remember, epinephrine is what gives that dark color to the dark pigment to the liver, because of which you see a dark liver. So remember, Dubin-Johnson, dark liver or a pigmented liver. Are we all clear with this? That was your question. Grossly pigmented liver is seen in. So remember, grossly pigmented or dark liver is seen with Dubin-Johnson syndrome. So Dubin-Johnson is your conjugated bilirubin increase, which also brings us to the end of the session. I hope all of you have been able to solve these questions easily. They were not difficult at all. So hoping to, just a second please. Small technical issues today did trouble us a little, but I hope not too much. So thank you all for joining in. I just want to remind all of you that tomorrow on my Telegram group and on the Unacademy Telegram group, I'm going to post 45 questions as a mock test. I'm going to post 45 questions as a mock test at 7 o'clock. So all of you can attempt that. And day after tomorrow, that is on 2nd of December, we are all meeting at 5 p.m. on the Unacademy platform. 5 p.m. at the Unacademy platform. It's a free live class for everyone. The crash course that you know that is going on, we'll be talking about hematology. So all of you will definitely benefit from the same. So hoping to see all of you in class. And tomorrow's mock test, I would recommend everyone to attempt that, right? Okay. Yes, lungs and liver also, the important topics I will be covering day after in the 2nd December session. You're right. Okay. Thank you so much, guys. Dr. Usha, how would a histoplasma image be? I'm sorry I don't have that right now, but what I can do is after class I can post it on Telegram. Histoplasma are usually very tiny yeast-like 2 to 4 micron organisms, okay? They are very tiny dot-like 2 to 4 micron organisms. So I will post a picture and I'll mark it for you on Telegram right after class so that you can see the same, right? Okay. Thank you so much, guys, for joining in. See you all in the next class. Thank you.